welcome back. In chapter 18, we're discussing gender, sex, and addiction. So, because of the historical research, literature chooses a binary gender approach where we're discussing men and women and not other forms of gender approaches, right? So, little information exists about experience of people who identify outside of that duality, outside of that binary duality, right? So, however, the use of alcohol by women began to draw criticism in the 1830s when author Harriet um, Martineau identified only four reasons why women might drink: cultural oppression, vacuousness, self-medication, and prescribed medication. And increases moral and religious influence on government led to the intemperance movement in the late 1800s and 1900s. One disturbing trend was in modern times that emerged of binge drinking as a pastime for young men and women, right, particularly during their college years. The relationship between gender and drug use and is also driven by cultural impressions and moral thinking. In the 1800s, the prescription medication often contained addictive substances like opium, cocaine, and cannabis. The typical opium addict was a middle-aged Southern white woman taking medications prescribed by her doctor. In the 1950s, barbiturates use became prevalent as these drugs were prescribed for sleep, and amphetamines were prescribed for weight loss. In the 1950s, the age limitation to alcohol for adolescent girls and boys ages 10 to 14 showed male to female ratio from 4 to 1. Girls and boys are now equivalent in their early drinking, right? For girls and boys under 12 years of age, the rate of alcohol use is 13.3% for both genders. Today, use of drugs and alcohol disorders continue to be quite pervasive. In most categories of drinking and alcohol use, men are most likely to use than women are, right? However, women use prescription drugs, including pain medications, tranquilizers, and stimulants, tends to be equal or exceeds that of men. Sex and gender differences that exist with regard to process addiction, such as gambling, sex, and pornography addiction, right? So it is worth noting that there is some differences there. Sex and gender differences do appear to exist with regard to underlying motivations, brain reward processes, impulsivity, hormones, social, cultural factors, and stress responses. An example of this is that men tend to gamble more frequently than women do at the age of 2 to 1. 93 to 98% of gambling anonymous participants are male, right? That shows a clear relationship between differences in gender for gambling. So let's talk about women and addiction, some of the biological considerations. The relationship between gender and addiction is affected by moral climate, legal precedents, and gender roles, right? Women metabolize alcohol and drugs differently than what men do. In regards to alcohol, women intoxicated after consuming only half as much of a man metabolize differently, right? They develop cirrhosis of the liver more quickly and a greater risk of death due to alcohol-related violence or accidents. The time between onset of a problem of drinking and physical problem is shorter than that of men. The phenomenon is commonly referred to as telescoping. Alcohol-dependent women are also more susceptible than men to liver damage, heart problems, osteoporosis, cardiovascular disease, and breast cancer. When we talk about drug use, women tend to use more heavily and become addicted more quickly than their male counterparts. Problems specific to women include malnourishment, hypertension, sexually transmitted infections, to which women are particularly more susceptible for. So younger women are most at risk of accidental death or injury of suicide or overdose related to their drug use. Middle-aged women are more likely to develop breast cancer or osteoporosis. Older women use substances are prone to bone fractures, such as their hip, or due to uncommon falls. Psychological problems go hand in hand with addiction. For example, 78% of men and 86% of women with alcohol use disorder also meet the criteria for at least one psychiatric diagnosis. Women differ than men specifically that they appear more likely to develop an affective disorder prior to the addiction, whereas men are more likely to experience the dependency first. Social considerations. Social factors may influence how women seek treatment for addiction and affect the likelihood of their becoming addicted in the first place. Women development of problems with drinking appears to be linked to relationships, linked to their social context, their external environments, the level of supports. Traditionally, societal tends to judge women problem drinking and drug use more harshly than what those of men. Women entering treatment for addiction are less likely than are men to have family support and are more likely to have lower socioeconomic status, less education, and be unemployed. So women who parent with with an addiction, pregnant women who use alcohol put their babies at risk for developing fetal alcohol syndrome. Women with children may be hesitant to enter treatment for fear of retribution or investigation by social services, and they lack child care when they're in treatment. Right, can be a barrier to actually attending treatment. The cultural stereotype that women who drink are more likely to have sex be a part of the reason that women are often the victims of sexual assault, one of the influences. Women who experience violence are more likely to be addicted, and addicted women are more likely to experience violence. Men continue to be the primary consumers of alcohol and drugs. Heavy and chronic drinking can lead to increased heart problems as well as stroke and high blood pressure for men. Young men for ages 18 to 29 are most at risk for developing alcohol use disorders. Young to middle-aged men who drink heavily or develop alcoholism have been elevated chance of mortality compared to their non-drinking counterparts. And older men experience a decrease in risk of mortality due to alcohol use compared to their younger counterparts. Men are more likely than women to use most type of illicit drugs. Men are 3 times more likely to use marijuana on a weekly basis than women. Men are also more likely to smoke cigarettes and use non-prescription opiates like heroin, or use inhalants, or suffer from severe complications from cocaine use. Some studies have shown that aggressive boys who may have an imbalance of testosterone are more likely to use substances that are non-aggressive peers. Men who use cocaine are more likely to be diagnosed with attention deficit or hyperactivity disorder. Men tend to use drugs and alcohols in an effort to stimulate or suppress feelings. They may also use substances such as alcohol or cocaine to increase their perception of personal power in their lives. While addicted women tend to present with affective disorders such as depression, men are more likely to exhibit social pathology. They're also more likely to express overconfidence and rationalization with regard to their addiction treatment. Men also tend to externalize or blame others for their addiction. On a lighter note, addicted men tend to have more positive outlook on their lives than women that have a potential addiction. Men appear to use substances in an effort to create a community, to feel connected. Developmentally speaking, while adolescent girls and boys tend to use substances at similar rates through experimentation, young men tend to demonstrate problems drinking and drug use behaviors earlier than young women do. Men also tend to have social supports from their family members once they decide to seek treatment from their substance use and problems. Like women, men are more likely to be the victims of violent attacks while under the influence of alcohol. Let's talk about treatment overview and history. Since the 1940s, the Minnesota model of treatment provided the backbone for addiction counseling. Currently, 95% of treatment programs in the United States are based on this model, which incorporates residential treatment, education of the disease model of addiction, and attendance in 12-step meetings. Despite the fact that this model has a long history of addiction counseling, it is not necessarily the best treatment for all clients, particularly women. It is important to remember that Caucasian men developed both the Minnesota model and AA, Alcoholics Anonymous. Regardless of theoretical orientation, the relationship between counselor and a client is simply the greatest predictor of treatment success. One way to improve the odds of a successful counseling relationship is to pair clients of a counselors of a cultural features such as gender. Addiction counselors can increase the odds of client success by addressing gender issues as an integral part of the counseling process, examining the client's problems in a societal context, acting as an advocate for clients experiencing gender repression, engage in collaborative counseling, facilitate clients' freedom to choose success. Confrontation is a hallmark of the Minnesota model. Has been shown to be less effective for women clients who prefer a collaborative treatment modality. Also, the Minnesota model places clinical focus on individual pathology. Social conditions, societal conditions such as discrimination, oppression, abuse, and sexism are not considered as factors. The 12 steps programs are also not a good fit for women. The 12 steps may actually further minimize women who are positioned as powerless prior to entering treatment. Women may experience greater reluctance to seek addiction specific treatments. And women-only groups offer benefits. Female-only groups provide a space for women to attempt to recover. Currently at my residential facilities, we do separate at the residential 3.5, 3.1, and 2.5 levels of care. We separate our men from our women to make sure that they have opportunities to have that safe space to operate under a trauma-sensitive environment and to provide both males and females with time away from the opposite sex or time away from things that can trigger them or whatnot and give them a safe space to be psychologically safe in treatment. So gender-specific treatment needs. Traditional counseling, which often focuses on expressing of feelings, may not be entirely appropriate intervention for men, but particularly in the early stages of the interventions is very helpful. Interventions such as goal setting, creating lists and contracts, homework assignments may be more beneficial in drawing men into the counseling process. Addiction counseling must address the whole client as opposed to just the addictive behaviors. For men specifically, focus on early and concrete concerns about employment, health, family issues, acknowledge their needs outside of the addiction. Case management is a really important factor that can help those clients because in their madness they can lose sight of their not lose sight of themselves, but lose sight. They can have lost their resources, not have IDs, not have social security cards, birth certificates, things that they need to actually operate and get employment. Attacking those areas can be very beneficial. So transgender clients, there exists a dearth of research regarding transgender and transsexual people and substance abuse. It's often lumped with lesbian, gay, and bisexual community for addiction research purposes. One hindrance to effectively measure substance use disorders in this population is that the exact number are unknown. The stigma surrounding the lack of support that cultivated, the shame in hiding the inability to be themselves. From a social justice perspective, counselors must be aware of transgender clients suffer from alarming social discrimination, including extreme poverty, harassment, and discrimination in education and employment, housing discrimination, and homelessness. Similar to the transgender population, little literature exists regarding the addiction of regarding addiction of addictions counseling and clients with DSD. Like transgender clients, clients with DSD, which is disorder of sexual development, may experience gender identity confusion, shame, concern about sexuality, and social stigma. Gender differences also exist in regard to treatment outcomes, right? So women are more likely to relapse than were men. They're also more likely to drop out of outpatient treatment after the first session than where men were. And men, on the other hand, are more likely to enter treatment because of family opposition to use or court orders. That concludes our lecture on chapter 18.